So in fact, this session should serve as a nice prelude for the dinner, on which is going to be very much on the topic of how to bring forward the health promotion messages. As Juan and I, we use the UNFPA document to frame the content for this workshop. You know, we had very much in mind the issue of advocacy and the different dimensions that it takes. So one of the talks, which is I'll have the privilege of giving you now, which is looking at revisiting the scientific validity of the anti-vaccine arguments. And this certainly was an important concern back in 2006, 2007, when vaccination eventually began, and countries were coming to grips with the decision-making process and how to convince the opposing views on vaccination. It has become less so over the years, mostly because we have ignored the noise that's out there, and we just have just hammered forth with our own goals in cervical cancer prevention and vaccination. But lately, the pace of the criticism from the anti-vaccine camps have accelerated, and they have taken a special tone of sophistication when it comes to the HPV story specifically. So it helps if as a community we eventually equip ourselves with the understanding of what mindset the other side has in terms of criticizing and proposing this message. And it is a combination of different ways of doing things. So as key opinion leaders, as you all are, if we can at least look at a catalog of what the anti-vaccine messages that are out there, then we can be better armed to respond to that and eventually convince those that are going to be educating the trainers and implementing all of those wonderful measures that we have looked at over the past 2 days or so. So with this backdrop, let me just go on and tell you what I'm going to be talking about. This is my disclosure slide. I don't have any conflict of interest despite all the wordy statements that you see in the slide. I don't have a conflict of interest, but I have lots of association with industry, as you can see, and I'm damn proud of it. In fact, 30 years of research would certainly have done quite a bit in terms of influencing the field, as I have done over such a long period of time, but nothing comes close to the ability that I have had to influence industry in bringing the products that we're talking about right now in terms of making a difference to women's lives. So what I would like to, first of all, is just to set us back to a zero-based intellectual budget here in terms of what would be the key benefit that we want to bring with all the tools that we have at our disposal, both in primary and secondary prevention, namely vaccination and the new screening technologies. Is to eliminate inequality that exists in cervical cancer prevention, and I don't need to, I would be preaching to the converted here because you all know what I'm talking about here. And then visit the scientific validity, or rather the lack thereof, of the arguments that exist that have been voiced against HPV vaccination. Some of them are quite sophisticated, in fact, and they are based on interesting and quite thoughtful thinking there. Then we can't dissect all of the arguments. There are just too many of them, but if at least we can in the 15 minutes that we have here to just dissect some of them. And they're mostly based on epistemological arrogance of people who tend to play overly conservative approaches to looking at the science. And the cherry picking of data when some of the opponents, they go and they look at the FDA data and eventually how they criticize. And then also request for demanding the impossible and eventually artificially raising the bar as if it were a scientific good posture in doing things. So here's the inequality, and that I don't need to describe to you. In global can, I mean, how many times talks in this workshop and the one next door have shown the global can data 2008, many times. You know, different shades of color. I'm using blue for this one. And the conference starts tomorrow. And you're going to see this over and over and over again. So nothing to it. We have Latin America and the Caribbean, Sub-Saharan Africa, Southeast Asia, the inequality that already exists in the system. These are countries that have their own opportunistic screening, and they have middle classes, strong middle class, they have screening of women who are captive, they have very low risk of cervical cancer, and then the vast majority who fall through the cracks. So here's one argument here, and let's call it the like mother, like daughter principle here. So we want to counter this like mother, like daughter principle, which affects, which brings this inequality in cervical cancer prevention, essentially, is the fact that vaccination is already, even before publicly implemented vaccination programs were implemented in 2007 and beyond, there was already opportunistic vaccination as soon as the vaccines were approved in 2006, and people paid out of pocket to do that. And mothers brought their daughters to be vaccinated in clinics, and eventually they were protected. But these daughters are going to be like their mothers. If a mother was conscientious enough to know that vaccination, HPV vaccination would protect their daughters. These are also the same women who are also captive to screening programs, and they have the best available co-testing technology in the United States or the best available cytology elsewhere to be able to be protected. So these daughters are going to be vaccinated. They're going to grow, and 20 years later, they're going to be like their mothers, and they're going to be captive of screening programs. And so the problem is not so much in this particular set of context, but it's the other side of the equation, which is the fact that we already know that most cases of cervical cancer, they are right now cases of failures of screening. Women who have inadequate screening histories because they were never screened or because they were improperly screened, insufficient frequency of screening or low quality of availability. And these are the mothers who do not receive the messages, the health promotion messages about HPV vaccination or screening. Eventually, their daughters are not going to be vaccinated, they're not going to be reached by screening. And as these daughters grow up unvaccinated, they will be like their mothers. And eventually, that's where cervical cancer eventually concentrates in a segment of the population with this cruel logic of the like mothers, like daughters situation. So here's a premise that can eliminate this state of affairs. The vaccination needs to be universal and needs to be targeted pre-exposure as a pre-exposure prophylactic primary prevention initiative, and that will raise the inequity that exists in the system. We had wished to have done that with cervical cancer screening via organized screening programs, but as you know, this is a rare form that doesn't exist everywhere in the world. So, and there is already evidence for this like mother, like daughter concept. As early as 2009, 3 years after the onset of vaccination, Kaiser Permanente had already done, and this was published quite prominently in the American Journal of Public Health, looking at mother-daughter pairs and with the Kaiser Permanente HMO. And this is quite a large study, 148,000 mother-daughter pairs, and they looked at the history of screening in the mothers and the associated vaccination history in the daughters, and both completion of 1 dose as well as 3-dose regimens. They looked at different ways, and I'm capturing here the results in just this particular table, but essentially this is the message. There's a strong association between the mother's screening history and the daughter's vaccination history. So the like mother, like daughter principle already exists, and in countries that have opportunistic screening as well as opportunistic vaccination, this is likely to be augmented. And that's certainly the case in low and middle resource countries, which have middle classes, which have segments of the population, which have, because of their own devices, they choose what's the best approach for being treated. So elimination of that, there's only one solution, which is to eliminate that via universal preventive strategies, such as what we've been discussing over two days. And the problem with them is that there are some barriers that are perceived about both vaccination and screening. Let me concentrate on vaccination, which is the topic of this discussion here, but cost essentially is the most important one. As you well know, it's unaffordable where most needed. Well, it used to be a more severe problem back last year or the years before, but it's becoming less so, but it's still a major barrier. It's unaffordable where most needed. There's lobbying. In my own country, in Canada, in Alberta, we have tremendous lobbying in the province of Alberta from the Catholic School Board, and this is very much a case that's being very carefully watching in the media. There's the Catholic bishop there, which opposes very strongly vaccination in its school board. So this is making Alberta having different pockets, 85% coverage of vaccination in most of the province, and in Calgary specifically, in the Catholic School Board, is 17% coverage only because the bishop opposes that and sent letters to the parents. So in addition to that, you have just the plain vanilla variety anti-vaccine activism, which in Canada, a country that tends to have a lot of the green thinking around nutrition and all of those things that people tend to confuse with important health messages. So there's a good prevalence of anti-vaccine activists and so-called experts who eventually become the mouthpiece for these activists, and or people who just like to be in Canada for the liberal attitude of a country such as Canada, which they oppose big capitalism, big pharmaceutical companies and all of that. So they love to vilify Merck and GSK and many of the biotech companies that are out there. Then you have the myths that are very difficult to dispel, safety issues that are around anything such as vaccination, which there's no safe health intervention, and certainly vaccine is not a perfectly safe health intervention, but it's the best we have and one of the greatest achievements of the past 2 centuries. Sophisticated arguments such as type replacement, I'm going to tackle that briefly. Fear of promiscuity following vaccination. By the way, this was the very argument that our bishop in Alberta was voicing. And lingering requirement that there should be proof of a reduced risk of cervical cancer before we adopt an intervention that's just focused on an intermediate endpoint such as high-grade lesions. Well, we should have randomized controlled trials of cervical cancer, reduction of cervical cancer incidence, and that's what people keep saying. And there's also just the plain inertia of changing things. If you have, Canada is one of the countries that have enjoys the lowest incidence rates of cervical cancer, so it doesn't seem to be much of a perception that we have a trouble, we have a situation that needs to be changed. Just screening works, why change that? And this is certainly the case in many of the Western European countries as we see that. Anti-vaccine activism has interesting aspects to it, and a number of the mindset of the anti-vaccine activists, we're not going to be able to change. You know, they're just the nature of what the enemies are out there. There's just fear of real but rare or unsubstantiated vaccine side effects, just plain misinformation, and those would be presumably easy to counter, wouldn't it? There's difficulty with numeracy. You know, people who just have difficulty understanding probabilistic statements, which are formed the base of all the scientific cogency that we use behind modeling and epidemiologic thinking and demonstration of risk and all of that, which requires randomized controlled trials and all of that. And people just don't understand, they just refuse, they're totally blind to all of that. There's denialism, simple refusal to believe the evidence, and they just ignore it. And so if they can't use your basis for facts, then there's no dialogue. There's also unsophisticated cognitive personality that a lot of people have, and the acceptance of very simplistic assumptions and without any critical thinking about that. They just read media reports. They see Oprah Winfrey inviting her own personal doctor there, and the personal doctor goes in a show as broadly watch this Oprah Winfrey show, and this doctor says that, well, I go against my whole community of gynecologists, and I'm going to say something against vaccination. It's better to give nutrition to your daughter rather than give a vaccine. Mind you, this was exactly what happened. I have a slide on that, but I'm not going to show you. It's for some other day. There's also those who think that anti-vaccine activism is just the plain right thing to do. So they just side with the bandwagon there. And there are those who sadly have had a personal or family experience with a real or perceived vaccine injury. And some, these people may eventually amplify their messages by going to the proper venues. And all of these these insights, they came from this wonderful article that I would recommend you to add to your library of preventive medicine. And this is an article that came out this year, The Clinician's Guide to the Anti-Vaccinationists Galaxy, and published in the Human Immunology by Poland and Jacobson. Wonderful article, I highly recommend. So here's some of these arguments and how they come to us. We're all scientists, or at least we practice science. We translate knowledge from science. And one of the arguments that's frequently voiced in science is to be conservative. And between being conservative, being overly liberal about accepting an argument, usually people are not going to criticize you if you play the conservative side of things and your judge is being honest and in your approach. And here's from a recent article in a very reputable journal, Journal of Epidemiology and Community Health, and the authors are saying, well, look at the title of the article, "A Long Story Made Too Short." I mean, look at the cynicism of the title of the article. Surrogate variables in the communication of HPV vaccine trial results. A long article with several pages, and here's a core paragraph. Epidemiologists love surrogates. I'm one of them, by the way, because many studies would not be possible without them. We could not be able to prove cause-effect relationship if it weren't for the opportunity of having intermediate endpoints. So when events are rare, or the time between intervention and the outcome is long, surrogate variables are used to fill the gap. Epidemiologists hate surrogate variables because they introduce an additional step in the chain between intervention and eventually the outcome in terms of causal thinking, and thus an additional source of error. To introduce surrogates means to increase uncertainty and perhaps an error. So they're leaving that doubt, and they go and they recite in this article a long list of examples in medicine in which we thought that we had when we thought we had targeted a suitable intermediate endpoint to prevent the final outcome downstream, eventually didn't work. You know, we have lots of examples of that in medicine, and they wanted to include in that same list of arguments high-grade cervical lesions and cervical cancer by saying that, well, here's another one. So just by targeting intermediate endpoints such as high-grade CIN2 and CIN3, that does not prove that you're going to reduce cervical cancer at the end of the day. So this, in a different framework, has been voiced by editorialists. And New England Journal of Medicine, Charlotte Hogg, who's, mind you, is someone with quite sophisticated thinking. She is or at least she used to be back in 2008. She was the president of the Norwegian Cancer Association, or the Norwegian Medical Association, I should say, and another editorial in the Journal of the Medical Association, the JAMA, in 2012. No proof yet that it can prevent cervical cancer. And here I submit to you, these are the counter-arguments that this community is so comfortable in accepting and doesn't even think about any lack of logic in this. Well, there's high efficacy in preventing precancerous lesions. I mean, do we argue with that? I mean, two different vaccine companies that are certainly competitors in what they do, and they have arrived exactly at the same conclusion with those two vaccines. So absence of evidence, which is what Charlotte Hogg is proposing, is not evidence of absence. And certainly one should not be using this side of logic to prove the other one. So, but let's use 70 years of what we already know about secondary cancer prevention via screening, which is the fact that sensible judgment, based on understanding that if you intervene on the natural history step by just screening and detecting those high-grade precursors and treating them, what's going to happen is that whatever the end-stream consequence is not going to happen, which is preventing cervical cancer. What's wrong about the logic of preventing that same thing that you want to treat by just not having it in the first place? Wouldn't that also prevent cervical cancer? So what's so difficult to accept this logic? And mind you, it is not a simple concept to prove when you have this extreme, overly conservative argument that these editorialists utilize. Type replacement, and that's a very sophisticated argument that we see frequently, and it has happened because analogy is a very powerful scientific argument. It happened with pneumococcal vaccine, so why not with HPV? So let's see the story and try to dissect this. So we know that type replacement, and sometimes we call it risk replacement in different forms. I mean, they're not exactly synonymous, but they, in terms of public health impact, would be the same. But that's the depletion of 16 and 18 via vaccination. It's success of vaccination eventually could make a shift in the distribution of HPV types because we eliminate 1618, and the ecological nature of 1618, once evacuated, other types would fill up. I mean, with the pneumococcal story, is based more on genetic, a very dynamic genetic situation where you have a very fast genetic changes there, that you would have fast mutation rates, and eventually there could be one type that could mutate and eventually fill that up. Well, we're talking about DNA virus here. in which it has been calculated by a number of molecular biologists that for each, it takes about 10,000 years for one one mutation, one base pair change to be fixed into the HPV genome. So it's certainly not in our generation that we're going to see that. But that's not the final proof. It's just the argument saying that this is a DNA virus quite fixed. It's not an RNA virus, not the HIV. It's a different story altogether. But we do have also evidence from other sources. We know from simple epidemiologic studies, observational studies looking at co-infections, that we also have, there's no proof that HPV types they compete. Thus, if you eliminate 16, eventually another type will take over that ecological niche. Several studies have shed light into co-infections and how they co-occur, and there's no hint that this could be the case. Also, unlike the story with pneumococcal, we don't have a saturation of the hosts here. You do have always a fraction of susceptible hosts that can always be occupied. So if there were type replacement, if there were competition, those hosts would have already been occupied by other HPV types that would not be targeted by vaccination. The problem is that these arguments eventually are being voiced by those who want to delay things. So we should, as opinion leaders here, we should counter those countries, those ministries of health and those jurisdictions and say, well, just in case, let's get some baseline data in our country and roll out a study of HPV type distribution before we adopt HPV vaccination. This is frequently voiced, mind you, in official documents by different countries. So here's another argument that has been voiced frequently by the cherry-picking argument here. So if you go in the FDA data that's filed in different places, you're going to find that with so many different endpoints, eventually just by chance alone, some of these endpoints are going to be statistically significant one way or the other, just by chance alone. So it's just a question of doing too many multiple comparisons. And eventually this is what some of these authors have done. They have just looked at the list in the FDA and eventually proposed what the problem is. And they found negative values for vaccine effect, which could be an indication, mind you, of this presumably real or unreal HPV type replacement. So here's what one of the studies has done, and looking at one of the trials of one of the vaccine manufacturers, looking at the protocol 013, which had been published, and they found a minus 54.9, and this is the confidence interval, which is very broad, and as you can see includes 0, but it sort of suggests to a potential increased risk of lesions among those who are vaccinated, which is certainly something that you would be alarmed, anyone would be alarmed. Well, mind you, it's just a chance finding. The same study, a different protocol, much larger in terms of the size of the person time, found that this is exactly a chance finding. So it's nothing to be excited about. It just happens with any study that publishes lots of different outcomes. Safety. Safety is perhaps the one that's going to be the hardest of the arguments to counter, because you can never prove in science the null hypothesis. You can never prove the lack of a fact. You can prove the existence of an association, but you can never prove the lack of fact. So one of the criticisms is that companies have not done enough to demonstrate that the vaccine is safe. Of course, I mean, the primary endpoints of the vaccine trials have been efficacy, and they haven't targeted safety. Of course, they have done reasonable, within the precision that they have, the power that they have to target efficacy, they also have reasonable precision to target safety, but not the exquisite exquisite safety that one would want to be able to satisfy the critics here. And if you just the plain simple fact, the safety data that we have for both HPV vaccines are the most well documented for any new vaccine out there. We're in 2012. Vaccines were approved in 2006. This is the highest bar that has ever existed for any new vaccine. And one vaccine that against a sexually transmissible disease that happens to be oncogenic, a virus that causes cancer. So you can't think of a more heightened level of awareness about a particular vaccine. Other counter-arguments. There was no waiting period for the adoption of other vaccines with much lower standards of proof, and inaction also has a cost in terms of morbidity and mortality. So delaying, because we want to satisfy all of this, would have cost thousands of lives in terms of action that would not have been taken. So here's just data from the VAERS system at CDC. This is already 1 year old, a little over than that. It's, the VAERS system is one of the best sentinel systems we have. It's operated jointly by CDC and FDA. At the time, 35 million HPV vaccine doses distributed in the US through mid-2011, 18,000 reports, 8% are serious adverse events, 68 deaths. And the serious adverse events, 8% are below the VAERS average of 10 to 15% that they record for other vaccines. I took the liberty of calculating the reported, comparing the observed number of deaths recorded in VAERS using that person time accumulated in the VAERS system, and I calculated the expected number would have been 10 times higher, because you would just expect that people would die at any point in life in this particular age group and gender. Of course, I used the mortality for the US population at the time, and you get a number that's 10 times higher. So that shows you that how fallacious the conclusions can be. Reports of Guillain-Barré syndrome after HPV vaccination, comparable to the rates and the background rates in the unvaccinated population. The FDA did a post-licensure review not too long ago, this year, and they reviewed data not only from the various reports, the vaccine safety data link study, and the manufacturer's data as well. And all of this was reported. And again, the conclusion, just to make a long story short, impossible at this point, is that there were no safety concerns for the quadrivalent HPV vaccine, which was primarily used in the US, and recommendation to continue safety monitor, which is a good thing to do. There was a consensus also recently reached by the major health authorities, FDA, CDC, WHO, the European Medicines Agency, and the European CDC. To date, no safety concerns for the use of the QHP vaccine. And by the way, this applies also to the bivalent vaccine, have arisen from ongoing surveillance studies in females and also taking into account studies in males. And again, monitoring with post-licensure adverse events has not turned out anything. But just for good measure, we're going to continue with surveillance. So there's nothing in society that would not think that it's a good idea to eat an apple a day, and that, of course, applies also to continued surveillance here. But just to look at the cruelty of that logic of requiring the manufacturers to conduct the trials that would be able to detect these adverse events at the levels that the VAERS system has been able to record. This is the size per arm of a randomized controlled trial to detect with 90% power an excess of 10%, because that's what they would want. A highly safe would be 10% increasing risk due to an intervention. So an adverse event rate of 88 and 0.8, and if you just look at the ballpark of the adverse event rate at VAERS system is 0.03 to 24. So that places you somewhere between the first and the second column all the way to the third column. So it would require, just for the safety endpoint, a trial in the hundreds of thousands, perhaps 1 million women per arm. I mean, this is just an impossibility but that's the high bar that they want the manufacturers to do. Well, the existing trials, the collection of vaccine studies conducted by both GSK and Merck, both phase 2 and phase 3 trials, have already passed the $1.5 billion mark. So just to give you an idea of how expensive this would have to be. Now, with these sentinel systems, they're based on very clever observation and recording. They're not complete, of course, but they have recording that's ostensibly done and carefully conducted. If we wanted to think from a purely observational epidemiologic perspective here, what we would need to be able to monitor and identify these excess risks due to vaccination, or presumably due to vaccination, you would need to think in terms of two cohorts, non-vaccinated population and the vaccinated population, eventually follow them up over time. So you have follow-up time, you have the notation here, and you have a number of cases for the individual health events that you want in both. So the formula here would indicate what would be that relative risk, that risk ratio of those events over time in those populations. So if ideally, in an ideal world, you would have collected data on confounders that would have affected the relationship between the intervention here and potentially the health event. So of all of those 6 numbers that we need, which is the number of cases, the number of individuals in those 2 cohorts, and the time, and to make the follow-up time, of those 6 numbers that we need, in reality, the only one we have is this one. And that's what the public perceives and makes a big fuss about what the causality is. So they only have C in the vaccine, number of cases in the vaccinated, and they try to make a big fuss about potential causality issues. Well, that being said, scientific reasoning alone is not sufficient. We need, in fact, smart advocacy, and that has to come from you and the new tools of social media that we're going to hear next, and eventually later on this evening, and with Mrs. Sandra Buffington and her team, and tomorrow as well. And these tools of social media will help us to understand what these arguments are and be able to reach out to the public with those counter-arguments and eventually show that these things work not only for vaccination but also in screening. Here's an example that was quite successful. I think it happened in the United States, and it certainly was very common in Canada. It was the so-called Movember. It's the month of November for men to grow their mustaches, and eventually this is a way of signaling their support for prostate cancer prevention in general. So Canadian women are very imaginative, and they came up with Julina. And so the same way that men can shape their mustache, women can also shape on the parts of their body, or the body part of the hair, just to signal their support for cervical cancer prevention. Thank you very much.